Hello, everybody. I thank you for attending this presentation about health promotion program that will be soon implemented in our hospital to improve smoking cessation among patients. I am Dr. A from the Public Health and Health Promotion Department. This presentation comprises of 5 sections. First, we will briefly explain the reasons why we decided to implement this smoking cessation program in our hospital. Second, we shall introduce the stages of change model, which constitutes the theoretical framework for our program and its different applications. Afterwards, we shall highlight the important pros and cons of this model. And finally, we shall present a multidisciplinary approach that involves all of you to support the success of our program. A recent survey showed a rising prevalence of smoking among our patients, with approximately 25% declaring being active smokers. After strategic planning and several meetings with the hospital management, we decided to seize the opportunity of inpatient setting to provide personalized smoking cessation counseling to hospitalized patients using a one-to-one approach, deploying the necessary time and dedication. We acknowledge the support of the hospital managers who accepted to hire specialist nurses and provide the financial and logistic support needed for this program. The program aims to assist patients towards quitting smoking and targets adult smokers who are hospitalized in all inpatients departments. The principal, but not the sole actors, will be specialized nurses who are trained to provide one-to-one interviews using the stages of change model. In a simplified definition, the stages of change model, or trans-theoretical stages of change, was first described in the early 80s and was first applied in smoking cessation. As the name implies, this model uses a combination of theories to provide a stage-wise description of the behavior change process. It had rapidly gained popularity over simplistic models that viewed motivation to change as a binary outcome in an input-output cognitive and behavioral model. Instead, the stages of change model frames the behavior change process into a continuum of discrete stages of motivation and actions toward change, which are the result of multiple internal factors such as beliefs, attitudes, emotions, self-efficacy, etc. The stages of change model defines 6 stages corresponding to gradual levels of an individual's preparedness to change a given behavior. Clinically wise, this framework enables adapting the health intervention, for example, a smoking cessation program, to the specific level of preparedness or stage of each patient. It is therefore important to identify the stage of each patient to determine the best intervention. As such, this model enables designing dynamic health promotion programs in accordance with the complexity of the human functioning. The first stage, called pre-contemplation stage, corresponds to absence of consideration for quitting. This may also include denial of the negative effects of smoking or adverse beliefs or attitudes towards quitting. In the second stage, contemplation, the patient has a critical reflection about smoking and becomes increasingly aware of its negative effects and the potential benefits of quitting, yet no action is made at this stage towards quitting. In the third stage, preparation, the willingness to quit is clearly expressed, and the patient may initiate efforts towards quitting, such as reducing the number of smoked cigarettes or changing some adverse habits that are related to smoking. In the fourth stage, action, the patient has made the action of quitting, but may perceive adverse effects of smoking, such as craving or other psychosomatic withdrawal symptoms. When the quitting goal is sustained over a significant period of time, the patient enters the maintenance stage. At this stage, the patient copes well with withdrawal symptoms, if any, and perceives the positive effects of quitting. Finally, the relapse and relapse stage is more properly an event that occurs during or may occur during the action or maintenance stage. Lapses and relapses do not indicate failure to quit, as they are considered part of a cyclic process that ultimately leads to smoking termination. To each of these stages, a clinical definition was proposed to enable consistent implementation in the clinical practice. Following this framework, the health promotion interventions are implemented gradually to make the patient progress throughout the quit process. Patients in pre-contemplation stage can be described as having a combination of cognitive barriers to quit, such as misbeliefs about quitting or smoking, indifferent or negative attitudes toward quitting, or adverse emotions. Interventions at this stage aim at raising awareness and knowledge about smoking hazards while triggering a critical thinking about the pros and cons of quitting. Nurses ask and guide pre-contemplators to think about negative aspects of smoking and any potential reasons or benefits of quitting, and also disadvantages of quitting and how to overcome them. It is important that the information produced during this intervention is the most personalized possible to reflect and address the actual beliefs and attitudes of the patient. As the patient moves to the contemplation phase, interventions aim at reinforcing confidence and self-efficacy in quitting in order to build capacity for change and grow the quit decision. Nurses will reaffirm the patient's specific reasons for quitting and assure that cravings for smoking will disappear after prolonged cessation. More importantly, capacity building should take into consideration any environmental barriers to quitting and potential solutions to overcome these. Furthermore, we inform the patient on the availability of specialist support to plan, initiate, and maintain quitting. Once the patient enters the preparation stage, interventions aim at guiding and supporting the decision-making process. We set the quit date at a reasonable timeline and establish a contract to quit smoking, which includes personalized reasons and goals, as well as guidelines and strategies to facilitate quitting and how to seek specialist support. From the quit date and throughout the quit journey, the patient is informed of the available pharmacological and psychological options to support and maintain quitting. Another important intervention is to educate the patient on how to deal with eventual lapses or relapses and how to positively integrate these into the quit process without impacting motivation or goals. Now let's take an overview on the pros and cons of the stages of change model. One of the most remarkable strengths is to be intrinsically patient-centered, in that it enables adapting the intervention strategy to the patient's specific context and needs. Also, its framework describes the change process in a logic that is easy to understand and apply by providers. It was tested in several problem behaviors, notably in other addictions, dietary habits, and physical activity, etc. On the other hand, the stages of change model has been criticized for not providing explanations of the mechanisms underlying the different stages. Furthermore, the model presents stages as being mutually exclusive and that one patient should be classified in a single stage, while in reality the stages overlap and patients may move onwards or backwards in the process. This categorization constitutes a challenge or confusion for providers when it comes to classifying the patients in practice. The other limitation is that the uptake of the program depends on the patient's awareness of willingness to participate in the program. Otherwise, patients may miss this opportunity. To overcome the latter limitation, we propose a complementary measure called Make Every Contact Count. The Make Every Contact Count is a multidisciplinary approach that consists of using each contact of healthcare professionals with patients to deliver a brief intervention towards a behavioral risk factor, such as smoking, diet, etc., and encourage towards a positive change of that behavior. The actors of this approach are of two categories. First, health professionals, including doctors, nurses, etc., of all departments, and their actions consist of implementing the so-called 5A strategy that consists of asking the patient of his smoking stages, assessing his smoking amount and related factors, and advising him or her to quit by informing about the availability of the program and assisting or arranging an appointment with specialized nurses. The other category of actors are administrators and managers who can promote the visibility of the program by distributing brochures and posters in open spaces and strategic locations. By implementing this complementary measure, all of us will contribute in enhancing the recruitment of patients and their uptake of the program. This will also enable raising awareness among families and companions and engaging their support. The hospital commitment to fight against smoking will be further highlighted, and multidisciplinarity will be fostered between our teams. In this slide, you see a summary of the complete strategy, including the two interventions, along with the respective actors, processes, and objectives. Thank you for your attendance.